Alright, so this is the assignment for 682, the 5 questions about the shoulder. Doing this assignment was a little difficult to come up with the questions. Since we haven't learned the shoulder, it's kind of hard to come up with questions when you don't really know exactly what to ask. So a lot of my questions actually stemmed from stuff that I've seen with Kyle, my husband, and his shoulder. So, and some of them are kind of broad. But the 2 people that I chose to talk to or ask these questions to, I chose my preceptor Nate over at Glendale just because I knew I would see him every day, so he'd be an easy person to ask. And then I also chose to ask Alan the questions. So my first question: what do you consider is the hardest thing to learn about the shoulder? When I asked Alan this question, he said that the hardest thing for him with the shoulder is just the mechanics and the fact that it's like 4 joints all in one, and that they work together, and that the shoulder has all these different degrees of freedom, that it doesn't just do flexion extension like the elbow, but it does internal rotation, external rotation, flexion, extension, abduction, adduction. So just the fact that it goes, it's more complex and associated with other joints. He also said that, it's harder, the knee, we're able to somewhat assess the meniscus, even though it's a deep structure, but with the shoulder, it's kind of hard to get to that labrum to be able to assess all of those structures. So just how difficult it is to get those deeper structures in the shoulder. When I asked Nate, his answer was that surgery and the rehabilitation part is kind of hard with the shoulder, because it's not as straightforward. Some people, if it was like a torn labrum, some people will opt to have surgery, some won't, depending on what their sport is. And as far as rehab goes, with coming back post-surgical, it's not as straightforward either as compared to the knee, where you can be weight-bearing, non-weight-bearing. So it's harder to know what they can do and what the surgeon is going to allow them to do with the shoulder, because like I said, it's not very straightforward. The second question I asked was, what interventions would you do for a slap tear? This is one that kind of stems from my husband, and he thinks he has a labrum tear right now. So when I asked Alan this question, he said that he would try to figure out what caused the slap tear to begin with. So he would look at function and the posture and work on those if they needed to. One thing that I really learned with this question for Alan is I didn't know, a lot of times a slap tear is caused by a forceful biceps contraction. So that biceps tendon, one of the biceps tendons, comes in and attaches to that labrum. And so if somebody is like forcefully contracting that bicep, then that can potentially rip off a piece of that labrum, which makes sense why Kyle possibly has one right now. It's his arm that he holds onto the bull with, so if that jerked his arm down and he forcefully contracted that bicep, then it completely makes sense. But go back to the question. He said that he would look at what caused the slap tear, try to work on that, but overall, no matter what with a slap tear, pre-surgery, if they choose to repair it, most of them will get repaired, but that they will work on scapular and thoracic stability. And that answer was spot on with the answer for Nate. Nate said for his intervention for a slap tear, he'd work on scapular stabilization. He'd work on strengthening the muscles around the shoulder. Obviously work on pain control. when we talked about this question, he said, obviously, a lot of times surgery is probably what's the only thing that's going to fix it, but addressing their pain control and trying to get them through the rest of their season if it happens at a opportune time is kind of, when I was talking to Nate about it, he said, this question kind of relates back to our first question about what's hard about the shoulder, is that there's so many different options, and it's not cut and dry like with the knee. If you were going to return to sport and you had a torn ACL, you're going to have to get that ACL repaired, whereas with the labrum, you can continue on. It just may be painful. So the third question I asked, what are your go-to exercises for the shoulder? So for that question, Alan said that he would do all the functional tests and begin with what they can't do. So just like what we learned in class, if they can't do flexion, then they'd work on flexion, and can't do extension, then they work on extension. He said overall, though, for shoulder, he always will do something in order to work on retraction, because our society has it to where we are so rounded posture, just working on improving that retraction and getting those muscles working. So through some pulling and posterior exercises, he would work on improving that retraction. Nate, when I asked him his go-to exercises for the shoulder, he actually has a paper that he got when he was working with his college and undergrad, that is like a series. So you always see the hip mobility series, and so he actually has a shoulder mobility series, which he didn't happen to have it on him when we had this discussion, but some of the examples that are on it are like scap sags and wall assisted diamond push-ups. So just trying to work on all those aspects of the shoulder. My next question, in your setting, do you reduce locations or do you refer? So this question again comes from my husband. I know PBR, they'll try to really reduce the dislocation. I have a feeling that a lot of my answers, I was expecting them to say that they would refer. So it's kind of interesting to see their answers from Alan and from Nate. So Alan said, if it was a first time glenohumeral joint, he would never try to reduce it, unless it was a wilderness thing, out hiking with a buddy, then he may try to reduce it. But otherwise, in his setting, he would never try to reduce a first time. He said, if it was a chronic patient, he may attempt to, he would never actually touch the patient, but he would, give them instructions on how to, bend over and kind of let gravity pull it back in. So he may instruct them on how to self-reduce it. But, so that was Alan's, and Alan's answers lined up pretty well with Nate's. Nate said that he would, never directly reduce it, and he would probably do some of the self-reduction if it was a chronic case, but most likely if it was an acute case, he would refer. Last question was, what is the most common shoulder injury you've seen? So Nate and Alan's answers were pretty much the same. Alan said his main thing that he would see is just some general mechanical shoulder pain. He said, outside of that, the next thing would probably be shoulder impingement, but he defined both of those terms as being kind of an overall general, not really specific thing. And when I asked Nate, his answer for the most common injury was general inflammation, whether it be, to try to get a little more specific, he said, rotator cuff tendonitis or some biceps tendonitis. So just that general overuse of the shoulder are usually the most common shoulder injuries. So I kind of went through it as I was going through the questions. Both Nate and and Alan had pretty similar answers on everything that I asked. And I mean, that makes sense. They're both it makes sense that both of their answers, match up and line up. I don't see anything too crazy different about either one of their answers. All of it seems to make sense to me. It was definitely, I feel like this assignment was definitely a good warm-up for next week when we start working on the shoulder. So I'm excited to get ready.